Greetings from eMedi News, Heartcare Foundation of India and Board of Medical Education, Mulchand Medcity. Welcome to our show, Chat with Dr. KK. We have with us Dr. Rohit Aggarwal, who is Assistant Professor of Medicine Rheumatology, who is Medical Director, Arthritis and Autoimmunity Center at University of Pittsburgh, US. Welcome to our show.
Thank you.
Biologics, extensively used in our country. But when it comes to a average physician or a MD, it goes above our head. And now biologics are used in cancer. We talk about autoimmune thrombocytopenic purpura, and now people are talking about biologics can be used to raise HDL. And in fact, no disease is coming where biologics role is not coming. You talk about inflammatory, so GI person says inflammatory bowel disease, biologics. And I will not be surprised and tomorrow cardiologists will come back and say, if you want to prevent stent thrombosis, if you want restenosis, some sort of biologics will come. Yes. Today they are costly, they are going to become cheaper. Yes. Let's try to understand the concept of biologics.
So the concept of biologics, it's very, it's great. It started with rheumatology and it's going into other fields. So the concept of biologic is, what is biologic first of all? So biological drug is a drug which is against one of your own biological parameters, whether it's chemokine, cytokine, one of the receptors, if you make a drug against your own body normal hemostasis functioning components, that's biologic first of all. So it's the reason the cost is so high, it's very difficult to purify it, very difficult to make these drugs. So the overall biologics, it started with anti-TNF agent, which is one of the most commonly used prototype biologics. Now we have 5 different anti-TNF agent which is used in rheumatoid arthritis, IBD. Very commonly used biologic is anti-TNF. What we find is there are about 4 or 5 of anti-TNF agent. One of them is infliximab called Remicade, which is an infusion given every 8 weeks. Other ones are
for the benefit of my people, anything which ends with MAB
would be a biologic.
Because
MAB
means anti-TNF.
MAB means monoclonal antibody. Now it could be anti-TNF, it could be something else.
So MAB. So one is look for MAB. MAB. If any drug ends with MAB, it is basically a biologic.
It could be. It may not. It would be biologic, but they will be. They can be a biologic without MAB.
Oh yes,
right.
But then that MAB
would mean
will be a biologic. Okay. Now again TNF, anti-TNF.
So anti-TNF, as I said, there are 5 major anti-TNF available. The prototype is Remicade, which is given every 8 weeks infusion, which is used for rheumatoid arthritis, ankylosing spondylitis, as well as IBD and other diseases. Other biologics are etanercept, which is injectable every week, sub-Q injection. Another one is adalimumab, which is Humira, which is injectable every 2 weeks. Then you have certolizumab, then you have Simponi. So these are 5 biologics. Certolizumab and Simponi is used every 4 weeks, injectable, self-injection.
So they are same except for the duration?
From my standpoint, they are completely same. There are no studies shown one is superior than other. They are completely same. It's the patient preference, cost, and do you want infusion or self-injections? How, what the patient doctor interaction is. Now if somebody has mild disease, I tend to go with every 4 weeks because it's easier. Somebody has more severe disease, I tend to go with every 1 week or every 2 week drug, just because we know these drugs are more older.
So we as a physician need to recall only one group, and that's anti-TNF.
Anti-TNF,
and
all are the
depending
same.
upon the duration, you may have to choose the drug.
Yes.
Okay. Yes. If one practices, one is fine.
Yes,
okay.
Absolutely.
Any side effects?
So major side effect is actually in this country, if you think about, is TB. So it reactivates TB because you need TNF to form your granulomas and keep the dormant TB in check. If you give anti-TNF, it disrupts the granuloma and can reactivate the TB. So that's the major risk factor for anti-TNF. So when you give anti-TNF, we have to do a PPD or quantiferon gold or ELISpot test, whichever suitable in a patient. And if it's positive, whether you're living in India or anywhere else, whether you have a BCG or not, you have to give INH treatment for about 9 months, or rifampicin for 6 months before giving anti-TNF. Now a lot of time we give 3 months of INH and we continue it, but we start the TNF right away after 3 months or 1 month. But protocol is...
So in India, all of them probably will receive INH.
I wouldn't say all of them, because your threshold could be 5 millimeter. If you're above 5, then above 10. But yes, if you're PPD positive, you should give INH. In fact, it's been shown that it doesn't matter if you have received BCG or not. If you've been exposed and you're getting anti-TNF, you should get INH to help, and that drastically decreases the risk of TB, drastically.
Okay, so apart from anti-TNF, what are the other biologics?
So other biologics that we commonly use.
Again, let's finish it up. Anti-TNF are used for one, rheumatoid,
and closing spondylitis.
So one is arthritis,
IBD.
Inflammatory bowel
disease is the second major category of that, and those are pretty much two big categories.
So anything which is inflammatory, whether it is bowel or arthritis,
it should be TNF mediated. So that's why.
So TNF mediated inflammatory diseases, you give them anti-TNF antibody. What next?
So the second biologic I would like to talk is rituximab, which is commonly, everybody knows rituximab is a anti-CD20 molecule, which basically decreases your B cell population, and it's being now most commonly right now being used for rheumatoid arthritis. It is also being used now for ITP. Is very commonly used for ITP now.
Cancers.
Then obviously cancer is where it started. Other areas that is being used is vasculitis, ANCA vasculitis. It's a very good treatment is rituximab. So rituximab, the major problem is obviously risk of infection, because you're wiping out the B cell population. So that's the major risk. The second risk factor that we think about with rituximab is PML. So higher risk of PML. Most of the cases with PML has been seen in patients with cancer or HIV or some other problems. So, but we have seen some cases with pure rituximab causing PML. So you have to be, or any other infection, you have to be worried about overall risk of infection. But those are the areas which is used. It's given once, it is given 2 doses. There are 2 regimens of rituximab. One is weekly regimen, which is where cancer protocol is 375 milligram per square, which you give every week for 4 weeks, or rheumatoid arthritis or vasculitis protocol, which is 1 dose, 1 gram, and then 2 weeks later another one.
They are short-term therapies. They are not lifelong.
They're short-term therapies in the sense that you can have a mileage of about 6 months to 12 months if you give 1 dose of rituximab. So they are sort of a long-term, if you think about it.
But once in a year, something like that.
Once a year or once in 6 months, depends on the patient.
Okay, so one is TNF, that means anything ending with MAP.
Right.
And then you have a rituximab. The second group is rituximab for a B cell. Third thing?
So the third thing is IL-6 inhibitor, which is tocilizumab, which is a new drug approved for rheumatoid arthritis, which is given infusion every 4 weeks. What it is IL-6 inhibitor. So IL-6 is a potent inflammatory marker, potent inflammatory mediator, and you inhibit that, it decreases the inflammation drastically. And that's another biologic that's being used nowadays in US a lot, is tocilizumab, which is IL-6 inhibitor.
Okay, it is used apart from rheumatoid, any other condition?
No other use right now. All the other disease, see all these biologics, if you see their history, they are all used in rheumatoid arthritis first. Once it gets proven.
What about transplant? For renal transplant, we have now newer drugs.
Which one?
Something with B.
Those biologics I'm not very well averse with.
So when we talk about in rheumatology, these are the 3 groups.
These are 3.
IL-6, B cell, and
no, there are others. So the there's a new oral biologic. The first oral biologic just came out 2 months ago. It's a JAK2 inhibitor. JAK is a transporter which downstreams the inflammation, and it's a JAK2 inhibitor. It's called tofacitinib. Which is a drug that is being used now for rheumatoid arthritis. The first oral, we never thought that biologics could be oral, but this is the first oral biologic. So most likely you're going to see more and more oral biologics down the stream.
Is it as effective as infliximab?
It's actually very effective drug.
Oral.
Yeah, as effective.
And then it is given lifelong again, or 1 year or 6
like
months?
Similarly for about a year or 2.
At the moment, what is the cost in US?
Don't know off the top of my head the cost, but it's more costlier than infliximab and Enbrel.
And it is to be taken every day, or?
Every day, 1 tablet twice a day.
1 tablet
Easy regimen, has very little side effect profile, apart from obviously infection. Whenever you suppress the immune system, infection is the risk, but overall side effect profile is very low. We're still giving TB prophylaxis to these drugs, but not seen much.
Okay, my last thing is very clear then. When do we refer for biologics?
Whenever you're not able to treat with your traditional steroid plus one drug regimen that you're comfortable with, you should refer.
Is it only for a failure cases, or can it be the first drug in patient with a severe rheumatoid arthritis
We are using
to give it into remission?
So let's say if a patient comes to me and has already developed damaged joints, high titer CCP and rheumatoid factors, severe disease, I know this patient is not going to get better if I give them steroid and methotrexate alone. So I may start them early on with methotrexate and anti-TNF to begin with. So there is role in severe deforming erosive arthritis to start, as I said, start early and be aggressive, to be aggressive from the get-go.
So what we have learned from Rohit today is that biologics is a new treatment. Up till now, most of us at the level of physicians and the family physicians used to say injectable therapy, refer it to rheumatologists. But the time is going to come, and that's what has happened in the last 2 months. Oral biologics have come, and therefore all physicians and family physicians must know everything about biologics, because once a patient is on oral therapy, for a follow-up, they will invariably come to a physician or a family physician, and we should know about them. And as far as there are lots different types of biologists, just 3 of them we should remember at our family physician level. One is, that is, remember the word TNF. So there will be a TNF, anti-TNF drugs, and the second will be working at the level of B cells, and third will be working at the level of IL-6. Start recalling, because that's something which we were not taught when we were doing MBBS or an MD, something we have to learn new, get updated in this knowledge. And that's all for today. Let's thank Rohit
Thank you.
to be with us. We'll come back with one more show. Till that, goodbye. Thank you.